Hello, coworkers. This is Elizabeth Bouchard-Hall. I'm going to take a couple minutes to talk about stroke in the emergency department, early recognition, and first actions. In May, I was able to go down to the Albany Med Ischemic Stroke Conference, and as part of the stroke committee, we're going to be having some larger discussions on stroke and how we sort of take care of these patients in the ER. But first, let's just talk about where we are when these people come in. So we're all pretty comfortable with the classic stroke presentation using the acronym FAST. So face, arm, speech, time. And looking for unilateral weakness, facial droop, speech disturbance. Something that we were talking about at Albany Med was consider negative symptoms in stroke: loss of speech, loss of motor function, loss of feeling on one side, sometimes on both. And then next up is stroke mimics. Stroke mimics are non-vascular events that can appear stroke-like. Unwitnessed seizures, we may be just seeing the postictal period of someone and it looks like a stroke, but it's actually not. A tumor, a metabolic imbalance, vertigo, conversion disorders, and also some of these complex migraines that we see can appear stroke-like. Considering positive symptoms in seizures, so things that are added, flashing lights, aura, convulsive movements, smells, these are all things that may trigger to us that this may be a non-vascular event. These are generalizations, obviously just things to kind of keep in the back of our head. Stroke chameleons are what we're really concerned about. They're diagnoses of real stroke that may be missed. So we may be working up a patient for altered mental status, delirium, confused state, and we may actually miss the TPA window for treating ischemic stroke if the patient meets criteria, but we're sort of following this other road on the differential diagnosis. So if a patient comes in and they're presenting with atypical or a classic stroke, we want to get an accurate weight. This is very important for TPA dosing. We want to get a finger stick, rule out whether this is hyperglycemia, blood pressure, and SpO2. If we can get a blood pressure in both arms, that's great. We do not want to delay transport to CT, but if we can do that with the people that are there. First set of neurovital signs, jot those down. And if we have a pretty good story that this may be a stroke, good communication with our doctors, so getting them into the room within 10 minutes, involving the charge nurse to call the CT to hold the table, or our other team member, just using your resource so that we can all get this patient to where they need to be quickly. And calling pharmacy, I like to think of this as the report that we get from EMS. We're sort of giving a report to pharmacy so that they can know that they may have to, figure out their time schedule to mix TPA if we need it. And the transport to CT, the recommended time is actually less than 25 minutes. And 25 minutes can go pretty quickly. If we can bring the SOC cart to the bedside, that's a plus. So what can wait? If the person's a hard stick, labs can wait, EKG can wait. Placing the patient on the monitor, we don't want to get them all wired up, and we're waiting to get them unhooked to get them over to CT. If CT's holding the table, let's just get them right over there, shoot the image, and get them right back. And once we get back from CT, by all means, 2 large bore IVs, getting their labs, 250 cc bolus. That's a great time to shoot their EKG. And whether it's a quick call to the nursing home, speaking with family members that are there, let's get a really good story to see if we can put together what may have happened to this patient. This is also a good time to get the patient on the monitor. And I think we're all really good at this, until we know whether they have any deficits that may impede swallowing, we're going to keep them NPO. Handling of TPA, we're going to involve clinical pharmacists if they're available. They're a really great resource, and we're going to administer according to protocols and orders. The TPA and ischemic stroke protocol is being revamped, but it's also still a very good resource. It has a sort of a, paint by numbers of when we do vital signs, how we take care of a patient who may be receiving TPA. If TPA is sent to us and it's not used, we need to hand deliver that back to the pharmacy. We're not going to dispose of it in the department. It is very expensive, and it gets charged to our budget. So if we send it back, we can get a refund, and if we throw it away, then we can't. So that is just sort of the quick of how we're going to see these patients, some things that we should be keeping in the forefront of our minds, and then we'll have some further conversations about stroke going forward. I apologize I wasn't able to be at the staff meeting, and thank you for listening.